Hey everyone, this is Dr. Sorin, and I'm an anesthesiologist and pain specialist and board certified in both of those. Founder of the Idaho Pain Clinic. Wanted to talk today about epidural steroid injections. Now first you got to understand the anatomy. You've got the brain, the central nervous system, and the brain connects to the spine. And then in the spine you got what's called the central canal that goes down the middle. And then you've got nerve roots that exit at each level. So that's the C1, C2, C3, thoracic, lumbar. So all these have nerves that come out. And the analogy I use is you can either have a problem where the nerve is squeezed centrally, central stenosis, and to use a freeway analogy, I say it's like the freeway being blocked. Or you can have an exit being blocked, which is a specific level where the nerve is exiting, where it's coming out, it can be blocked. So what are common causes of pain related to that are either you can have a disc that bulges out and squeezes either the central canal, it squeezes it in the middle, or it can squeeze, you can have a lateral recess or a lateral disc bulge that squeezes where the nerve comes out. And so therefore, there's two types of procedures that we can do for that. Actually, there's more than two, but two types of epidural steroids. We can either do what's called an interlaminar, where we go between these two little pieces are called lamina. So inter means between, so we go between the lamina, and that is a much wider spread of the medicine. It'll spread up and down about a level, and it'll go left and right. It'll kind of go everywhere. The way I describe it is you can have a pitcher of water, you can decide exactly where you're going to pour it, but once it leaves your container, it goes on the path of least resistance. So that steroid is just going to spread wide. And one of the theories that of how it helps is also that it can wash away inflammatory proteins, and then we also put steroid in there, and the steroid decreases inflammation of the nerve root. And that's a common cause of pain, is inflammation of the nerve root. So one approach, like I said, is the interlaminar, where you go between the lamina. And the second approach is what's called a transforaminal, which means trans is across, and foramen just means hole. So this is the foramen is this hole or opening on the side where the nerves come out. So transforaminal is a much more specific type of block. So if you feel the pain is coming from one specific nerve, we can inject just that nerve. And that can have both a diagnostic and a therapeutic value, which means we can actually figure out if we think the right L4 is the problem, we can inject right next to that right L4 nerve and figure out if that's a problem. Oftentimes surgeons will ask us to do those injections so we can help figure out if two levels look bad, we can figure out the one that is the source of the pain. And so that's the transforaminal versus interlaminar. Think of interlaminar more like a shotgun approach. It's going to go broad and wide, and think of a transforaminal more, I call it the sniper approach. It's very specific to one level. And so, you know, when a patient comes in, we perform the injection, and I usually tell them it takes 3 to 5 days for maximal effect. And for a lot of people, this can help reduce the pain and break them out of the pain cycle. And for some people, they can avoid surgery. Other people may need to go to surgery, but at least it's an option we can try to help diagnose and mitigate and reduce that pain. Thank you for watching. See you in the next video.